Okay, welcome to season 2 of the Strength and Chiro podcast. Today we have some guests in person. First time ever, actually, we have guests in person. So I have Cole on the right, and then I have Luke in the middle. So welcome to the podcast, lads. Cole, how are you feeling?
Pretty good. Thanks for having me.
Well, hey man, it's good to have you. Have you seen some of you watched a few of our podcasts before?
I have.
You have, nice.
Yeah.
Obviously, we've had Luke on a few times. So Luke was in, we've had you on season 1, we've had you on in season 2. You were with us with the myth busting, which was like super fun episode.
Yeah.
Welcome, Dr. Stephen Redmond. I call him Redmond, but it's Redmond, and apparently he's the Tony Stark of chiropractic, which I believe. Welcome to your own podcast, Dr. Stephen Redmond.
Thank you. I had 2 days of a seminar on Friday and Saturday, so brain is just a little fried today.
A little fried, man. Well, unfortunately, we have the coffee here. This is kind of what you need. You need some coffee. You're going to have to enjoy it through the screen. A good friend of mine, Bryn, he's sponsoring the podcast with his company called Katana Coffee Co. Bryn is a business owner, a coach. He's also a fantastic powerlifter. And what I've done here is I've gone ahead and prepared in the weekend with some cold brews. Now, we were going to do some flash cold brew pours as well, but we're probably just going to do some hot brews. We've got some cold brews here. We also have our vanilla, and we also have some double cream. For those that are wondering what the hell we're doing, including Stephen, this combination with coffee is a drink called the Gentleman, and that is what single-handedly got us through COVID and chiropractic together. So it was like cafe chats and gentlemen. So we're celebrating these two guys graduating. We're going to share a few stories. Stephen's going to talk a little bit about curriculum, and then we're going to bring on Giles Gyer, who's going to talk a little bit as well and give us some feedback. So hopefully it will be informative and fun. So we're going to start with this. Okay, so this is a Kenya pour over. So what happens is you pop the top, you have the sachet like this, take the top off, you clip it to the sides like that. What a lot of people do is they have like a special pour over. This is just a jug, obviously. And so how fast you do it, the rate you do it, and how full you fill up this little sachet here will actually change the strength of the coffee. Do a little bit, get it wet, then add a little bit more. You can stir it. There's like all these things, right? This is not a coffee podcast, just to give you guys an idea. So I'm going to fill this up a few times. This is going to give us a real nice shot, of which you can then add hot water for a long black. You can have a short black. You can just have it as a pour over. You could add milk. You could, whatever you want, right? We're going to be adding the bloody cream and the vanilla. So that shot is going to sit there, and that's just going to, the aroma. I'm sorry you can't get this, Steve. I'm really disappointed for you. This is the Japanese pour over Kenya AA.
Not bad, bro. It's not bad.
It looks really good. All right, so shout out to Brand for sponsoring the podcast. This here, we've got that double cream in here. This is a Gentleman.
Cheers, lads. Oh, yes. It's on the money. Memories.
Stephen, what's the one thing you remember from school? And it can be positive or negative, right? You at your discretion. The one thing you remember about school.
It was exhausting.
Okay, that's good. I feel so bad that I should have sent you some over, Stephen. I'll send you some of this coffee. You like coffee, eh?
It's good, yeah.
I'm not going to go into some of the real intense ones. But I will share a story about a time where we just came off the COVID buzz. A lot of the COVID stuff for us was online, and we were told, like, you'll have enough time.
Happens for yeah. Right.
We were told with the COVID stuff, you'd have enough time. We're not going to throw anything on you. If we come back, once we come back to school, we'll have like time to prep. We go back. We're told you've got 11 exams in 7 days or something. Next week, whatever, a week after. So we were cramming. And one of those just happened to be upper cervical. Now, you're obviously aware of upper cervical, Steve. I wasn't a huge fan of it based on the fact that it didn't have a lot of evidence supporting it. And I remember we'd go up to the rooms and practice our toggles. I remember Cole was trying to help me with my toggles because I'm just so big and slow.
Still got videos of you, man.
Yeah. And so we were practicing, and everything is, the upper cervical curriculum was still based on static listings. So we're being told that the atlas has gone superior right, anterior, whatever. We're being told that things are moving and that our vector has to move them back. That's what we're being taught.
Yeah.
And so it gets really confusing. So you got to know where to stand, where to place the head of the table, where to crank it up. Like, you have to stand in the right place. Your hand has to be in the right position. There's like a 10-point thing you had to learn with your hand, your contact, your nail hand, all that stuff. Anyway, we go into the final exam for upper cervical, and we were tense, to say the least, because we had no preparation time, really. And the said teacher proceeds to throw out a listing that doesn't exist. pretty much.
Yeah.
And
Yeah.
now, me and Luke were partners for this. Luke just went white and just looked at me. I just started circling the drain. I was like, "What is this listing? It doesn't make sense." So I start setting up, right, to shoot from the hip, body right. Thanks. I do this setup, and I do all the setup really well. I start setting up on your whatever else, your escort or your C1 or whatever. And then the teacher's like, "No, that's wrong. You're on the wrong side." And I remember looking up to her. I was circling the drain. I was like, "This listing is not. It's not a listing. I'm not sure."
Yeah.
And then so she proceeds to tell me a new listing that she didn't say before and said that I was wrong. So she gave me the new listing. So luckily she told me that it was wrong and corrected me, but it was really her mistake. Once me and Luke got out of the exam room, we were like laughing our heads off because it was just one of those stories where like I nearly completely lost it, but I managed to pass that exam. That's probably one of the more mild.
But the worst part about it was the mentor actually assessing was dyslexic. So that's why the listings got confused around the way. Terrible, man. Terrible.
I got the lowest possible passing score on my toggle practical because I mixed up the hand that's the hammer and the one that's the nail. I set my hands backwards. So maybe I was supposed to have the right hand down and then the left hand on top. I did it backwards. And I was told that there was no way you could effectively clear out a subluxation if you did it with the wrong hand. I was like, what? Okay.
There's no way you can put that vertebra back into place if you've got the wrong hand on it.
That's insane.
We got that as well, right?
But while we're on the topic of upper cervical, I wanted to ask, how did they explain muscle testing to you? Did they ever bother to? Or did they just say, you just flick on the side of somebody's head and they'll magically tell you the vector in which their C1 is subluxated?
I don't remember the muscle testing.
It was the wizards thing, remember?
Yeah.
So basically, anyway, to elaborate briefly on what Cole was talking about is it's kind of one of the neurological indicators that they like you to work with.
You lost me.
When you're when you're building towards that listing, right? So you get all your muscles and whatever. And then at the end, basically, because we're working with static listings, you put the head position of the patient into certain positions, so lateral flexion, rotation, and tucking the chin slightly based on how that C1 is sitting. And you'll have the hand up like this and have the head in the position. And if the hand goes weak, it's kind of an indicator that level is fixated, essentially.
Well, we get up there. The mentor, whose name I can't remember, thankfully, at the time was we asked, like, how does this testing work? Like, what's the science behind it? And he's like, I don't really know. I don't know how it works. It just kind of does. Then he proceeded to explain to us if the muscle testing doesn't work, so somebody's arm stays strong, God forbid, during the tests, you can reset their polarity by going like that.
The glabella. What is it?
The glabella, and just rubbing on the front of their chest.
Yeah.
And that was the point that I think he lost a lot of us because
you're being very polite though, because you said whether or not you genuinely can't remember who it was. It was the person that was responsible for establishing this method of muscle testing in this way, right? Him and another person.
This was the guy who made
it. Made it. You know him. You'd probably know him if I said his name.
Genuinely could not explain.
Yeah, it was very awkward. And all three of us were sitting there asking that, and then my other friend, we were testing on my other friend, and he was like, he couldn't do it. And they were like, neurological findings. And I'm like, he's got a supraspinatus tear.
Yeah.
Ricky? Remember Ricky had a You remember that?
Yeah.
I'm like, that's useful for that.
Yeah.
Like, there's still an empty can.
Yeah.
But like, don't fucking tell me some bullshit about neurological. Depending on where you'd swipe from the vertebra across up, it's like you'd get a different reading.
Yeah.
It's crazy, man.
Speaking of polarity, I had a SOT practical, and we were told we couldn't walk counterclockwise around the table because it would mess up the polarity and it would subluxate the person on the table. And so on the practical, every time I had to move, I would purposely walk counterclockwise and then just pause and literally just pause until the instructor would be like, Stephen? And I'd be like, yes. And they were like, do you know what you just did? I was like, I just walked around the table. They were like, no, you just walked counterclockwise. You need to go fix that. I was like, what? well, yeah, you need to fix it. You just subluxated your partner. And I was like, oh, okay, I'm so sorry. So then I'd walk clockwise around the table back to my spot. And they'd be like, okay, can I begin again? And they're like, yes, go ahead. And I would start, and then I'd stop, and then I'd get to the next thing. I'd walk around the table counterclockwise again. I'd just pause for a moment. They're like, Steven. I was like, yeah. You walk counterclockwise. I was like, oh, I'm so sorry. What do I do? Like, fix it.
I know what you should do. Start walking around the mentor.
Yeah, to live
Doing laps around the mentor.
Yeah.
to live a healthy, unsubluxated life. Don't get within 5 meters of another person.
Perfect.
Just in case they might turn the wrong direction.
Okay, finish that. Cole,
Sorry.
you got to bottoms up. This is Katanako, Ethiopia, Japanese drip. The green bag. This one is phenomenal. I've tried it before. I didn't get sent many of these. It's very, very good. So we're going to do that.
I think I'm liking the what was the first one? Kenya.
Oh,
Yeah.
Kenya.
Yeah, this one is fire. This one is fire. I'm glad to hear you went through some bullshit as well, Stephen.
Yeah,
Oh,
it's
I went through bullshit.
nice to know what happens to people on the other side of the world, you know.
Especially,
Difference is they have MPI.
Yeah.
especially as a fresh
Which we tried, by the way.
Yeah,
We
but-
tried, so we'll get to that story.
We've got the producers standing by to retrieve and recycle the bottles.
There was another practical that was a fun story. I'm colorblind and I can't taste or smell. And in the neurodiagnosis practical, we were doing the practical and there was a cranial nerve exam in the practical. And my partner picked up the first card, and the first card was like optic nerve. And so I had to be able to read off the colors that he
Oh,
had
no.
on his card. And he got optic nerve, and we just like paused, and then we like laughed, and then we looked at the professor, and we were like, I can't do this. And he was like, why can you not do this? I was like, remember about my glasses? They're like, oh my God, that's right, Steven, you're colorblind. You can't do this test. I was like, I mean, I can do it, but I'm gonna fail the test. But yeah, just draw another card. So he draws another card. It's the olfactory is the next one he draws. Fun fact, Andre, he can't see the color red. He sees different shades of gray for the different shades of red.
During our time of our college, we had maybe one geriatric paper and one pediatric paper. They were terrible. Actually, I'm gonna tell two stories. That one from each.
Cheers.
So anyway, this pediatric paper, we were forced to take. Essentially, one of the requirements during the paper was at the end we had to do a practical exam. We had to use a freaking baby. Not everyone has those on standby, by the way. So we had to basically, you know, there are.
I've got one on standby.
Maybe
I got one in the oven.
maybe useful for next year. There was always a few mentors, you know, that had a couple of children that everyone would be lining up for, trying to get ready for the exam.
I got asked by my
Really?
intern.
Yeah. You said no way, bro.
I said no.
Get your hands off.
Are you a specialist?
Yeah.
No.
My girlfriend, she nannied for a family that they had a child, maybe 12 months, I would say. So I had to confront the family and ask for consent, really.
Give me a shot.
Yeah.
Ask permission.
Yeah. Ask permission if I could bring your child in to perform this exam, just testing basically like primitive reflexes and stuff like that. So they were all good with it. My exam was at the 1 o'clock, like on the dot, and my girlfriend had to leave from work, head to daycare to pick this child up. When she got there, the baby was asleep.
Babies do that.
But yeah, surprisingly.
Yeah.
She was asleep, and I was running overtime for my exam. So, you know, the mentor's on my case of like, where's your child? How long are they going to be? Blah, blah, blah. You know, you're meant to be at 1 o'clock. It's now 1:30. And so I'm on the other end trying to deal with her business and then calling my girlfriend being like, have you left? She's like, no, she's still asleep. We can't wake her up. And then long story short, it was like she finally woke up and brought her into the college. And my exam, by this time, I was an hour late and the mentor was fuming, I was like, you're a pediatric chiro or wannabe, so surely you can be considerate of it. I did not get good marks for that at all. Man, being forced to, you know, assess and treat kids and do assessments on it when it was 1 6-week course. And we spent the entire time shoving balloons up our tops, mimicking pregnant women and playing with like baby dolls. Like it was terrible.
It was shocking.
That was one circling the drain. And then the other brief one I have in the geriatric course, I remember me and Cole being at the back in the lecture room, and the same mentor at the time had x-rays of the pelvis up on the screen. This patient had avascular necrosis of the hip, and she was kind of explaining to that about it, and then proceeded to say, Do you not think if this patient had had chiropractic care from a young age that this wouldn't have happened? Maybe adjusting the SI joint and things like that. And we're just faces in the hands, bro. It's just these wild claims that these mentors are coming out with these miracle stories, and adjust T4, it can cure colic and things like that.
It's just these massive extrapolations that go against the scientific process. They're like, well, if this means this, then of course this would mean this.
Yeah.
And then they just treat that as fact without testing, without any investigation.
It's those wild claims that are dangerous as well, right?
It harms the rest of the profession. And
in certain parts of the world, including in New Zealand, you actually can't advertise that you can do anything more than musculoskeletal care. And if you do, you're actually breaching standards of your board. Doesn't stop people. And I see it. Unfortunately, we see it every single day. We see chiros doing that. And you know what? Other professions, we can't only shit on chiros. Other professions do that too. Yeah. I think the take-home message is not just to shit on chiros, but everybody can do better. And I think all of us will probably agree, like, it's always going to be the professional, not the profession. So you judge people based on what they're doing with their patients, what their belief systems are. But man, you go through these schools, you have so many stories. It's just so concerning. And often we'll connect with people from all around the world, and people have all similar stories.
Remember in lockdown when we were doing x-rays with Gonsid, remember?
Oh my.
And the mentor at the time was explaining to us how to do x-ray analysis, line analysis over video call during COVID era. And he'd be like, oh, so-and-so, 50-year-old patient came in with these symptoms. What level do you think is the cause?
It's not that they were trying to teach us a protocol so that we could get better and make our own decision. The mentors at one time during lockdown got together and they looked at an image and they had no idea who this person was. They just brought up an image and they were gloating, going back and forth, talking about they were diagnosing this person without ever seeing him. It was just an image. And they weren't just doing it like, oh, this might be true. And the caveat is we don't really know. It's just an image. None of that. Remember, that was just like they were just gloating about this, and we see this. Spinous is rotated to the left and pelvis. There's a lot of Gonstead talk and like fully judging and diagnosing this person just based off the image. And that was really like the start of us starting to question that and being like, hey, what's the diagnostic validity of this? And then when you start to look into it, a lot of it does not stand up against the scrutiny.
One of the big kickers was, when you're first learning that, you take it seriously because you're like, look, I don't know anything about radiology. If somebody tells me to put a line here, I'm gonna believe them. I went to one of the actual radiologists that works at the college, and I asked them about line analysis, and they said, "What am I, a fucking guru? No, I'm not going to use that." From that point on, I was like, "Okay, wait a minute, this might not be what I thought it was." Long story short, I had a chat with all the DAC bars at the college, and they all unanimously seemed to agree that it's a load of waffle, but there's no point in arguing with these people because they're just so convinced.
And that's actually a positive about the curriculum because now you've got people in the curriculum that actually understand the truth. The person I'm talking about. He would actually make an effort to teach us the right stuff, like legitimate red flags, legitimate stuff about radiology that we need to know. And then we would go to Gonstead class and it was contradictory. And so as much as we're bagging on one thing, which is like fine to do because I think that line analysis is inappropriate, just x-raying people for postural alterations or going after this subluxation thing that you can't really define within any real scientific literature. I think that's wrong. But at the same time, praise the curriculum that at least there was some solid education because I definitely thought the DI diagnostic imaging papers were really content dense and accurate and based off Joachim and Rowe, which I think is a good thing.
They were fantastic.
Yeah. It may not have been taught the way everyone liked, but the content was solid.
It was solid and super useful. And the stuff that we really need to know to be good practitioners, they covered and they covered well.
Yeah. So that's definitely.
Well, I think the reason why they're covering it heavy dense is they're expecting that 80 to 90% of chiropractors leaving the college are going to be having their own radiology suite in their practice. So when you're taking x-rays on everyone, you're not getting a DAC bar to write up reports anymore. You're whatever's popping up with that image you're liable for.
It's in-house, right? If you got your in-house x-ray, you do it all yourself.
Yeah, exactly.
And that's a unique thing to chiros.
Yeah.
That's so weird.
It is very weird, but it's funny because in that sense, the profession is almost trying to protect itself because they know a lot of people are going to go out and do x-rays in-house because they've taught you to do that as a way of increasing income. So then you've got other courses that teach you ways to mitigate risk associated with doing that.
Yeah.
Do you know what I mean? Like it's kind of like flipped on its head in a sense.
Yeah.
But it's definitely an issue, and you see people imaging far too much. And if you pull 10 people out of a crowd, they were all asymptomatic. We know that, depending on the body part, 8 to 9 of them are going to have some abnormality on imaging. So really you're going to rely on your critical thinking skills and ability, and your comprehensive assessment and detailed history. And I know that we preach this time and time again, but this podcast is not just about shitting on chiropractic. It's not just about always being negative. And we say this all the time, right, Stephen? We try to give some tools back to the people that are listening. I'm sure there are a lot of people listening. I mean, we are number 17 in the world at chiropractic podcast.
Still climbing.
So I think we do have a lot of chiropractors that listen, and I think there are a lot of frustrated chiros that are either in school or out of school and they don't really know what to do next. And I know that we probably have felt that way, do feel that way at times. I had to find a community. I had to find people to learn from. Stephen was part of that community. I don't live near Stephen. We have to connect over social media. You just have to do what you got to do, right, to find people that you want to practice like and align with those people. And so I'm really looking forward to having Giles on soon, because we're going to ask him some questions. But Stephen, is there anything you want to highlight about your curriculum that you thought was a real positive, right? Well, just taking a bit of a spin from the negative or funny stories, but what was something in the curriculum that you found was really helpful?
Honestly, like all the legitimate diagnostic stuff was phenomenal. Some of it was still a bit outdated. Like in my school, we never talked about Laslett's cluster at all. There were some tours that were teaching some of the diagnostic stuff, like the peds and the geriatric and stuff like that. But the general neuromuscular skeletal stuff, the internal or visceral diagnostic stuff, all of that was phenomenal. We had actually had some very, very good professors for those classes, and they did a great job preparing even the worst student to know how to recognize red flags within a history and an exam. So the diagnostic stuff, the knowing red flags, knowing when you shouldn't touch someone, when you probably can get away with touching someone, when you actually should touch someone, all of that is covered very, very well. That stuff is phenomenal. Everything else, not good. I can't say anything good about the rest of the curriculum.
My opinion was our pathology papers. Did we have 3 or 4? I can't remember. I thought the pathology papers were quite good. Yeah. Whether or not that was Jenna, the teacher, who was doing it, or it was the curriculum, I thought it was, if anything, it was too detailed for us.
I gotta agree. I think it was detailed to the point that since we didn't have the prereq knowledge that we learned in like lab diagnosis and Chiroman 1 and 2, practically remember it. Since it's not.
It was too much. I think if there was a negative, it would be that it was too much.
But it was comprehensive.
It was comprehensive. But yeah, that I would say was good. And then the neuro stuff was good in terms of our book. We did we ended up putting together all of our stuff into a book called the Neuro Quintessence.
That's still getting used to this day,
which is a legacy. It's still being used, and that's a fantastic book. Like we literally just thought about everything we needed from Neuro 3 and from Neuro 2 and 3, 1, 2, and 3, and then just put that into a book. And we actually re-illustrated everything so that we own the copyright. It's still circulating. And then once I left Chiro School, I had the neuro teacher message me asking for it, and then it's still being used to this day, which is cool. But apart from that, that's probably about it.
It's tempting to always look back on something that, like the college with just a negative lens and nothing but a negative lens because it has so many bad memories. But there was some really, really useful stuff that we learned. Chiroman 1 and 2, it was good to learn how certain conditions, whether they be visceral or neuromusculoskeletal, can present to your clinic and exactly where you need to refer them to. Because that's what was important. Recognize, refer with anything that's not within our scope of practice.
Yeah.
Those courses really built on stuff that we would actually be seeing. In terms of the musculoskeletal conditions, obviously it's a textbook presentation and a textbook way to treat it. It's funny that the recommendations in our courses were completely the opposite of what we were allowed to do in center and clinic. But overall, I'd say that they were positive courses because the people running them had a really good head on their shoulders. Fantastic lecturers. They've been to the college. They understood the kind of stuff we would need. So they made the content accessible and easy to digest.
Before we move on to you, Luke, should we pour another brew? This is the Kenya Japanese drip katana.
Cheers, lad.
And this is I brewed this pour over. Apparently, coffee aroma is more intense when it's warm, when a coffee's hot.
Yeah.
So you get more of a coffee experience when you drink coffee when it's hot.
So I got catcalled on the way back from this party I was leaving.
I bet you did.
No, because what's even better is that they came back around
For a second look.
Yeah, and then
Like, man, he's fine. He's muscly and ginger.
no, I'll never forget this. They said, good from afar, but far good. Never been roasted so hard. Came around, double take, roasted the crap out of me. Oh, that was shocking.
I would like to say, carrying on the discussion and the theme of, you mentioned Laslett, and also wanting to mention a few other names that are not taught. So obviously, like Laslett, fantastic. He's from New Zealand. He's a Kiwi. Obviously, Mackenzie is a Kiwi, and that's something. So we did not hear that name. We did not hear Mackenzie, Laslett, and most of all, McGill. We did not. There was no. It's not in the curriculum, right?
Yeah.
Well, half the people you talk to at the college, educators, they don't know.
Yeah, they don't know, and they've spent their time doubling down on what they know and not learning new things.
I would argue that they do know. They just hide and avoid from it. Because I remember the times in clinic, Cole started making like pamphlets for his patients to take home, because all we could focus on was solely adjustment, right? Everything else was bombarding the nervous system and too much. And he started making pamphlets for his patients to take home, fully referencing them, putting images, McGill reference, everything like that. After the initial consult with new patients, we have to basically go through a case approval with the mentor for it to be signed off and approved. And he got into so much trouble for starting up these pamphlets and giving them out to patients. Yeah, it caused a massive kerfuffle within the institute. So,
but quite literally, all it was just the McGill Big Three demonstrated. Just sort of functional core strengthening, gentle stuff. You show them how to do it, because you're not just going to, send somebody home with images and expect them to figure it out. But just like basic instruction, safety advice, how to do that thing, fully referenced. The same people that have been telling me, recommend exercises, recommend these people to start getting fit, lost their minds when I actually did it.
Yeah, I find that there's a massive hole in the curriculum when it comes to that. Whether or not it's a pride thing or not, it's really concerning. I will not speak on something unless I really understand it. And most people don't understand McGill. I think I can say that. I know enough people that know him, and I've read enough of his stuff. He is the most misunderstood and misrepresented person. So how could a mentor that's heard a little bit about him, or heard Bird Dogs or the Big Three, ever be able to give you, any type of input on that? They just can't.
Yeah.
There's in all fairness, there's been a couple. There's been there's been one shout out that was aware of all of the McGill stuff and actively encouraged me and helped me through that. But out of all the mentor interactions I've had, tens of different mentors, only one of them having a decent understanding of such a basic concept like core strength. Are you kidding me?
Yeah, exactly.
But they know that stuff's all long term, and it doesn't fit the subluxation model of treatment and care plans. So realistically, why would you give other tools and modalities to patient that's going to potentially stop them from coming back long term? That's where I kind of see it.
Well, that's the model you get taught, and you get taught a script to say, and you get taught an ideology to follow, where it's that wellness thing, right? So it's getting people back consistently. And it's once you have someone on your email list, or someone who's a patient, they're a patient for life. And they told us that if you're not communicating about wellness, you're not communicating. Remember, they nailed it into us so much that you need to scare your patient into believing that they have to be realigned weekly, if not monthly, for the rest of their life. And if you don't do that, then you haven't done your job.
Yeah. They guilt trip you into it in a lot of senses, which is really, really weird. One of the richest things I've heard, because that whole pamphlet thing was an utter waste of my time. They put you through so much admin, even after everything's assigned and proved. After that, they ended up implementing that lifestyle advice in regards to exercise or anything correctional in that regard, therapeutic outside the realm of straight adjustments, cannot be provided until the progress visit, which was like 8 to 12 visits down the line. So you're not allowed to tell somebody to do anything. And the justification was they want to see, why not see just how far they can come with chiropractic care? How is that ethical? It's like you're trying to prove a point. It's not a patient-centric.
You're using that patient to try to support your narrative, which is not necessarily correct.
I don't use my patients as experiments. I was sat down with another mentor, and they tried to explain to me that telling them to do therapeutic exercises along with spinal manipulations, adjustments, put too much stress on their nervous system in the initial
time. And we know that's incorrect based on the research, right? Because pretty much every modality with spinal manipulation is more effective.
God forbid they go on a walk after I adjust them. God forbid they go to the gym.
Yeah.
What am I telling them to?
Well, get out of alignment if they go to the gym, bro.
Line
on the pavement.
This means more money in your pocket. They go to the gym, they get out of alignment.
Yes, I joined with flip out place, bro. You know what counter mutates.
Oh.
We had a similar thing at my school. I had a friend, and he brought in a friend as a patient, and they had sprained their ankle. They didn't want to have their spine adjusted. The rule was you had to be treated 10 times, I believe, in the chiro clinic before you get referred to the rehab department. And it was also an extremity issue, and we didn't get credit for extremity issues. The clinician was like, you have to explain to your friend that they have to get something in their spine adjusted or they cannot be seen, and they have to wait like 10, 12 visits before they can even go see the physical therapist. Because there was a physio in the school's rehab department, and then chiro with the rehab diplomate thing that no one knew how to refer to because there were so many like things in the way of getting to it. I never referred anyone to rehab. A lot of them needed it, but there's too much red tape. They would literally sit in that clinic by themselves for hours on end, just waiting for 1 or 2 patients a day. It was so sad.
By then, you're already missing the acute phase of care, eh?
Yeah.
After 10 visits, like,
I better.
Yeah.
Self-limiting.
You've missed that 4 to 6 week
period. Let's chuck that in a study.
You'll be better. No, the problem is in a lot of these places, a lot of these colleges, to keep it general, you're almost at the mercy of the style of the mentor that's on that day. And I know that you guys have done that.
Yeah.
And you can almost get to the point where you have some people that are acting not aligning with the college's values at all in the way that they're speaking to you, the way that they're conveying information or communicating. And that's a real red flag. That's a major issue. Not a medical red flag, but just a general red flag, isn't it? But I just think there's a problem. And there's a story, I'll keep names out of it, but there's a story where, someone was giving stretches to their patient and the mentor that day just was annoyed or whatever, pissed off, and they just rinsed this dude saying like, you're not a personal trainer, you're not a physiotherapist, you're not even a licensed chiropractor yet. Like, you shouldn't be doing that. And this was someone out of our year. So this was years before us, before that rule came into place and stuff. But it's it's disgusting because what these people are doing is they're going through first, second, third year, then you're seeing patients, and like I said to you before, the smart ones are thinking laterally. They're starting to think critically and laterally. They're trying to problem solve, but they're being forced to use the same tools. So they're trying to fix issues they can't fix with those tools, and they're trying to force it, right? And they get frustrated, and then you get disheartened. You find yourself reaching out, trying to figure out other modalities. You implement those, you get good changes, and then the mentor who's having a bad day comes down on you.
Yeah, obviously there's no excuse for a lot of behavior from some of these practitioners. Because half the time they'll grill you in front of the patient, which is not okay. It's so not okay. It's so unprofessional. A lot of the limitations that we experience as interns is because we're practicing under somebody else's license, which only holds up halfway because anything we do has to be approved at a case approval, where a fully qualified chiropractor will sign it off and say, you are okay to perform these treatments on this patient. But even then, even when you do it, and even when you get it signed off in the case approval, you have to spend an extra 10 minutes defending yourself every single time you see this person because you get attacked by anybody on the floor.
Done x-rays, done scans. It's a double no.
It's an interesting point too, because it's like, you're getting to 4th year, you're starting to leave, and a lot of the mentors, think it's egos and things when it comes to interns. Half of them probably need to go through competency courses when it comes to keeping up to date with probably visceral stuff as well. There's a story that you'll like this one, Stephen. I had a patient who came in and who was being medically managed well. They had a DVT of the subclavian artery, upper extremity. And I chased up all their notes, their dispatch notes, scans, everything like that. And twice I was backed into a corner by a mentor telling me that I should manually adjust their neck after it was it was still there. It had reduced over time because he was on blood thinners and things like that. And I said, there's no way I'm touching this patient. He's like, but I will. It's my license. It's crazy, man. Like, these guys are they're wanting to get in, manipulate things. They need to be reassessed on some of this stuff, I believe.
Well, I think they're encouraged to go over the same stuff, right? So you learn a model. And for us, when I approached a teacher about MPI, she laughed, scoffed at me and laughed and said, why are you looking at that? We give you everything you need. The school's the best in the world. We've handpicked the most important things and put it into this package for you guys. That's a real problem. That's a real issue, you know? Okay, so I'm going to hold there. Obviously, we've got Giles coming in from the UK. Legend!
Dude, how's it going?
Can you hear us?
Yeah, I can, man. You all look like you're having a bit of a party over there.
Yeah, mate.
We are. So we've had cold brew, and with the cold brew, we've had vanilla essence, double cream. It's called the Gentleman. We were
Impressive.
caffeinated. Yep. So we've been doing that. We've maybe had like 4 or 5 coffees already. We're about to do the Katana coffee, Japanese drip Ethiopia. So I'm going to pop that in there. So this is a Japanese pour over, Joel. Have you had many pour overs in your life?
The odd one or two.
So I'll send you a bunch of these. I've been going through it today because it's a new sponsor of the podcast. Our conversation's been very interesting. Definitely ready for an expert opinion.
When are they coming on? Now tell me, Luke, have you graduated?
We've got the final results back, so they're all through. Cole's, me and him study together, so we're both in the same boat. But official graduation will be in about 4 weeks' time.
So you've both passed?
We're both passed, man. I tell you what, it was like the first weekend, we had off with just no assignments in the back of your mind. It felt like, daylight saving, when you gain a few hours. Man, it was just what to do with yourself, eh?
I don't know about you guys. When I graduated, you spent 5 years and it was just like 24/7. And then you graduate and it's a bit of an anticlimax.
Yeah,
Absolutely.
You know what I mean? You're a bit like, oh, Christ, now what do I do? But well done for getting through it anyway. That is a hurdle. So congratulations to both of you.
Can you say your famous line?
What? Get in and then, get the fuck out of Dodge. Yeah, you've done it. You've smiled. You've got the tick in the box. Now you can start learning and finding your own way, really. That's the key, I think.
We've just spent the last hour pretty much talking about a lot of the negatives, and then we've even highlighted some of the positives because it's important for us not just to sit here and bitch and moan. Before we go to Giles and we can get some wisdom, I did want to just finish the segment with a little bit of positivity because we've been ragging the shit out of chiropractic. I want to do a name and praise, right? Not a name and shame. So, Cole, I want you to throw out, this is the thing, Giles, we haven't been using names and we've been very broad on all the details, but this is a positive. Cole, you can start. Give us one name. You can name them because we're not naming to shame. We're going to name to praise. One good person, mentor, has to be a mentor or staff member through your experience at college.
Dr. Sally Bonning. She was phenomenal. She's one of those mentors that definitely a struggle to interact with when you're pressed on time because she forces you to really, really take your time and go through it. But her clinical knowledge and her encouragement to expand into more than just the realm of spinal manipulations was fantastic. And it was basically one of the first times that I had been encouraged to continue with looking outside of just adjustments. And her help and her recommendations on articles and books was super useful. She was an absolute pleasure to work with.
There you go. Name and praise. Well done. And Luke?
Probably John Bassano. John Bassano got 2. He was the radiologist at our institute, so on campus, and has been for 20 to 30 years. Very smart guy, teaches comprehensively, everything up to date. So yeah, he was great, as well as Waleed, who taught a lot of the visceral stuff, visceral conditions. Yeah, just really, really passionate for that stuff. And what's that?
That's 2.
Yeah, 2. It's got to be 2, bro. They're both even.
See, he's pushing his luck.
Yeah.
And what special mention I'm going to throw out there? Hannah?
Yeah, Hannah as
Dr.
well.
Gaskin, big go.
Hannah Gaskin? Yeah, she was fantastic. So there you go, a little bit of name and praise. Finish on a bit of a high. Stephen, do you want to throw out a name from your experience?
Oh yeah, Dr. Amos, he taught neurodiagnosis and he was the MPI advisor and he was just phenomenal. He's an open book. He also taught publication theories, but he taught it from a very evidence-based perspective. Like, here's historically what it is, but we know this isn't accurate. He was a godsend. They actually tried to fire him, and the students all riled to save him. He was someone that no one could be angry with student-wise. a lot of the administrators and faculty didn't like him so much because he would butt heads right back with people. But absolute amazing professor.
And Giles, do you have anyone that?
Yeah, no, we had a couple of good lecturers. I remember one guy was called Peter Colvin, actually. He was an Aussie guy. He was a physio, chiro, and an osteo, and he'd done all three and was very, very, very interesting bloke because he simplified a lot of stuff and basically told you not to sort of buy into the bullshit. So, I'd say he was pretty cool. But you'll always get one or two interesting characters at university, and if you can find them, then they're worth grabbing onto and learning from as much as you can.
Yeah, so a big thing we've talked about is there's a lot of people out there that are operating under an old model. They've been taught an old curriculum. There's a lot of issues with the curriculum, and I think one of those is kind of moving into a 21st century understanding of what spinal manipulation does and the effects it has on your patient. So they get to where Luke and Cole are, and they've got to go out into the world now and treat patients. What do you say to the person that feels like, hey, I know this model is not necessarily correct. It feels a little unethical to go make a living off this. What do you say to that new grad, and where do you send them to upskill to kind of change their paradigm, what they understand in terms of the ideology around chiropractic?
Well, I think that the question is a broad one, not just from chiropractic perspective, but osteo, physio, chiro. In fact, any manual therapy graduate. I started my degree because I had questions and I thought osteopathy was going to answer it. And I did my 5 years and I graduated with more questions than I had answers. I actually felt more confused when I graduated. Yeah. And the problem is it can be very easy to fall into a comfortable position with what you've been taught. As a human species, we love comfort. We don't like being outside of our comfort zone. But the reality is that you need to be constantly questioning what you've been taught, because everything changes. When I started my degree to when I finished, things had progressed over that 5 years. And the problem is, if you stick dogmatically to the view that and to the education you've been taught, you are going to be left out and left behind very, very quickly. And actually, when you start working with other healthcare professionals, you're going to come across like a quack if you're not current. So for me, when I speak to new graduates, what I tend to say to you is, like, great, okay, fine. You've graduated, which means you're safe. That's it. You've graduated, you've done your 5 years. It means you're not a complete and utter numpty. You know your anatomy, you know your physiology, you should know your red flags. Now it's time for you to learn how to be a therapist. Don't worry about the title, osteo, physio, chiro. I'm not interested in title. Title is ego. But now it's about working with outside of your comfort zone. Osteos, physios, chiros, work with other professionals, see what they do, see what's good about their profession, see what's bad about their profession, and amalgamate it into what you want to do. And so a lot of it is not looking at social media, getting into the journals, getting into the research, seeing where your narrative fits, seeing what you like, speaking to people in the industry that you think you can sort of align your concepts and ideas with and ideology with, but don't be afraid to challenge your beliefs. Because, man, I got taught some kooky stuff at university. And if I had not challenged if I'd not challenged my beliefs, I'd never have written any books. I'd never have published any research. And I'd be still stuck in my little clinic room correcting wonky pelvises 15 years down the line. And I'd probably be still, making a good living out of it. But, you have to be ethical. You have to, and I think for us, it's all about providing the best care to our patients. That's why we get into this, and so, in order to provide best care, you have to at least be evidence-based and current. But there is a comfort in sitting on your old school philosophies and theories, because it's hard to challenge stuff. It's hard to be wrong. It's hard to admit you're wrong. It's hard to admit you've been taught something that might be outdated. And it's hard work to continually educate yourself. It's a constant fucking job.
I told you he's good.
Yeah.
Yeah, look, fantastic. As always, makes a lot of sense. So what does spinal manipulation do? Because for chiropractors, a lot of the ideology or the profession is enriched and deep with that modality, right? That modality kind of represents a lot of the profession. I know there's philosophy underneath it and there's evidence-based people, But okay, we're looking forward now, 2023, nearly 2024. What does spinal manipulation do, and what does it not do?
All right. Very simply put, in my humble opinion, spinal manipulation is a very small part of the treatment process. It's a very fast and effective way to elicit symptomatic and functional modification for a patient. So if they come in and they're in discomfort or pain, I can use this technique to try to reduce their pain. If they have hypertonicity of a muscle, I can use this technique to reduce the tone. I can temporarily improve the movement of an area for that person. But in reality, it's just a way to help them feel and move a little bit better. It's a fast technique to gap a joint. It's not a corrective technique. It's not changing anatomical structures. It's not affecting the patient on this incredibly deep, almost vitalistic level that some practitioners believe it is. It's just a tool that we can use to create fast and temporary neurophysiological change. And it's the same as you mobilizing something, whether you manipulate it, whether you rub it, wiggle it, whack it, we can still get the same results. It's one thing. It's not the thing. That's where the misinterpretation has come from. People have sort of become this, I love the term, this mono-interventionalist concept, because people have now reduced their treatment to one technique. If it's that fucking good, I'll take the barista from Costa Coffee and teach him how to crack stuff. And I'll just stick him in treatment rooms, and I'll just fill them full of baristas that know how to crack stuff and make good coffee.
Or chat
or chat GBT. Yeah. I'll get chat GBT to do it. Look, I love manipulation because it's a cool technique. I was obsessed with it when I was a student, but the more I've developed my knowledge and skill, the more I've realized over the last sort of 15, 20 years is that actually, when I graduated, my whole treatment process was wrong. All I wanted to do was crack stuff and biomechanically change people and do all this structural stuff. And I actually didn't put enough emphasis onto the rehab side of treatment, which ultimately is the most important part of the process. So for me, manipulation is a small part of the bigger picture, but it is seen as this individual technique that is a magic bullet for all. And I think a lot of that's down to social media, but I think that was a long-winded answer to basically say you feel and move a bit better for a short period of time. And, you don't need to hear a click. It's not that important.
Yeah, and for those that are listening that are not familiar with Giles, you do not have an ego at all. If anyone should have an ego, it would be you, because you are probably the best, one of the best, if not the best adjusters I know. Regardless of that, right? You've published research. You've written, 6 books? 7th one?
6. No, I think I'm doing the 6th one at the moment.
Okay, so
it's another one that no one will read.
Exactly. No, just my mum and your mum will read it.
Yeah. I'm doing another coffee coaster.
We have multiple books. We have multiple research, right? So you've gone out of your box of osteopathy. You've challenged yourself, and now you've kind of given back to not just osteopathy, but anyone that's using manual therapy, because you've put some research out there, right? You've really just put your money where your mouth is in terms of putting in the hard work and not just talking. I really want to highlight this because your study review, spinal manipulation therapy, is it all about the brain? A current review of neurophysiological effects of manipulation.
2019 that was.
2019. So I'll put it up on the screen. And every single person listening to this episode, read it. You have to read this. Do not go and see another patient. Do not do anything else. If you've got plans, cancel them and go read this paper. It is phenomenal. And it is a beginning for you guys. It is a beginning. It's a starting piece. It is one of those fundamental things. People come to me and they ask me, what are some things I can read to upskill? And I say, go read the Gyer ETL review as well, because what you just said wasn't long-winded at all, but what you just said was a very easy to understand version of this. This is what should be taught in the current curriculum, and it's not. So could we hear a little bit from your point of view, Giles, on why you think curriculums are outdated? Do you think they're going to move forward and update? And what are you doing about it as one of the owners of OMT?
So, I'm going to answer your question. I feel very sorry for universities. I do, because it's actually quite hard. They're very constrained on what they can and can't teach, especially in regulated countries. They have a very strict sort of format that they have to follow. And it can be very hard for them to actually introduce new topics or new information or new aspects of the degree program, because it takes a long time for them to get that ratified and validated. So it's very difficult. I mean, I have to be honest, my big concern from an osteopathic perspective, when I look at London and I look at the universities based in London, they all teach stuff a little bit differently. And so you'll have qualified osteopaths. Yeah, the anatomy is the same, the physiology is the same, the differential diagnosis is the same, but the philosophies around what they're doing and why they're doing it, and other sort of tenets of the practice can be very different depending on the universities they've come to. There doesn't seem to be this sort of standard education. Actually, same with chiropractic. If you look at the Palmer unis, so I've done some lectures to, I think was it Iowa and was it California? I can't remember. Coast to coast, and you talk to the students, they're being trained in almost completely different concepts. So I do feel very, very sorry for some of the students and for some of the unis. It must be very difficult. I do think it's outdated. I think a lot of what the students are being taught is outdated in terms of knowledge around what it is we do and why we're doing it. And I have to be honest, I do think in the next 5-10 years there's going to be a massive shake-up, and I do think there's going to be an amalgamation of the professions. I actually don't think that's a bad thing. I think if osteos, physios, and chiros were to combine, I actually think you'd actually have a very, very good therapist. Someone who understands, physical exercise, rehabilitation, someone who understands the manual therapy, someone who has a holistic approach. Actually combine the professions, take the best of all of it and amalgamate it into one. I actually think that would be a really positive thing, rather than a divide between the three professions. Bring it all together. That's where I probably see the future of physical therapy going, especially I think for the UK. I do think a lot of it's outdated. I feel very sorry for the students, because they're paying, in the United Kingdom, £10,000 a year to be an osteopath, right? You pay 10 grand a year, £10,000. You spend 5 years of your life. That's £50,000 without taking into account loss of income, rent, rates, all the other stuff. So you could be down 80, 90, £100,000, and you're being taught stuff that's 10, 15, 20 years out of date. And then you'll graduate into a sort of a workspace where, you have to go against people who are probably, much more current than you are. It's a really challenging process. I do feel very sorry for graduates at the moment. It's a tough industry to be going into. But that's why it's so important that you do look outside the box and you continue to study, because it's a competitive market and you have to be on your game. You can't just rely on the stuff you got taught at university. You really do have to put the time and effort in outside of that, unfortunately.
Okay, I thought we'll do something interesting to highlight when it's appropriate to refer and not. I want you to say treat or refer. That's all you can say. I'm freestyling this, by the way, so if anyone has any ideas. So I'm going to do some basic ones, okay? Let's go with sports-related shoulder injury.
Okay, I'm happy to treat that.
Lower back pain in the second trimester pregnant lady.
As long as I didn't get them pregnant, I'm happy to treat them.
Okay, let's go with a 9-month-old baby with colic.
See you later, alligator. I am referring that to someone who's done additional training outside of my scope.
3-year-old toddler that's hurt his neck at school.
See you later, alligator. Yeah, no, referral for me.
General population above 50, smoker, lower back pain.
Don't have an issue with that.
How about 40-year-old woman presents with an insidious onset of progressive weakening of her left arm?
I'd probably refer them, especially if it's insidious. Ultimately, if you can't work out what the fuck's going on, refer them. It's pretty much common sense.
Yeah. You would hope.
You want to try to understand the mechanism of action for all things. But look, when it comes to referral, if it's outside of my scope of practice, for example, like I don't treat kids, I'll refer them off. I don't personally treat pregnant patients because I believe you should really be a specialist in that. I'll refer them off. If you have a patient, and this is good for new graduates, right? You can't treat everything, you can't treat everyone. If you have a patient that comes in and you're not sure, don't put your hands on them. Because no one's ever going to criticize you for being cautious, right? If you put your hands on someone and you fuck up, they're going to criticize you for being cavalier. It's not nice to stand in front of your governing body, gripping the rails, justifying your actions, right? I'm telling you now, it's not fun. So for me, caution is always key for a new graduate. Don't think you're Dr. House. Don't try and diagnose everything. If something comes in and you're just not sure, don't take the risk. See you later. You've got 30, 40 years of clinical practice. Don't be a mug. Don't try and change the world. Keep it simple. And if it isn't something you're happy with, have the confidence to refer to a colleague. Because like I said, no one's ever going to turn around and go, damn, you're too safe. But if you do something and something happens, you will regret having to go down that road. And like I said, no one wants to get into trouble in the first few years of professional practice.
This is a really interesting conversation because you go through a period when you're in college where, they're kind of pumping you up and teaching you all these red flags and all these conditions and diseases and stuff. And you kind of take it upon yourself. You almost think, well, I'm going to be the first point of call and I need to be Dr. House. I need to know all this stuff. And if I can understand this, then I can send a better referral letter and I can help the medical doctor with my diagnosis. And if someone's having this issue, I can do a regional exam and I can narrow it down before I refer. Which really, when you start practicing in the real world, is a load of bollocks, really, isn't it? Because don't get me wrong, red flags are very important.
You're absolutely right. Red flags are key, right? It's not how to. The key is not knowing how to treat something; it's knowing when not to treat them. That's the key. Any mug can rub something and click it and crack it. I see it all day long on social media. I see stuff where people are treating patients that they are clearly should not be treating them. As a new graduate, the key is with your red flags to know when not to treat the patient. That's critical. But as an osteo, man, I did all my ophthalmoscopes, otoscopes, stethoscopes. I did all the freaking eyes, ears, nose, and throat. Did I do it in clinical practice? Absolutely not. You come in and I think I need to do an abdominal exam, fuck off to A&E. You come in and you've got problems with your eyes, go to the optician. You come in and you've got some cardiovascular issue, I'm probably going to do a blood pressure test and then send you to the specialist. So for me, I never tried to be Dr. House. I always wanted to be a safe practitioner and trying to diagnose these intricate diseases, as cool as it might be, the reality is, look, you need to refer people if it comes in and something isn't right, and you need to refer them as quickly as you can. The doctor isn't going to sit there and go, wow, what a wonderful referral letter. Oh, brilliant. Fantastic. What a lovely guy. Oh, I'm going to put it on my wall. They're going to go, oh, osteopath. Yeah, see you later. And my colleague, he picked up a woman, she had crazy high blood pressure, and he picked it up as a new patient. He wrote a really good letter, sent her to the GP and the doctor, and the doctor literally ripped the letter up in front of her and said, that osteopath, what a freaking idiot, did the tests, put her on blood pressure medication, and then sent her away, right? So she comes back, and almost she was complaining to my colleague, going, well, he said you were an absolute idiot, blah, blah, blah. Well, what did he do? He put me on blood pressure meds. Right, okay. We've seen it. I've seen it time and time and time again.
Everything you're saying, bang on, but let me stress this. Build a network of people you can refer to. This is what I'm literally just regurgitating what Giles has told me off screen because I've learned so much from Giles. Build a network of people you can refer to. So, because people will be listening saying, hang on, you're telling me to refer, but then you just told me a horror story of where referring didn't work. But this is the key. The caveat, right, is to have a referral system of people you know and trust so that when you pick something up, you know the people that you're referring them to. Don't just blindly send them to anybody random. The other thing is that cross-country lines or international lines, things are going to change because in New Zealand, we have a GP, which is your primary healthcare physician, another person that can be a point of call. And then you've got free healthcare. You can go to the emergency room and get free healthcare, right? So that changes things because I know in America, the healthcare system's so messed up, right, Stephen?
We do see everything. So you need to know what you're comfortable with treating and what you're, more importantly, not comfortable with treating. If it seems like that's an emergency, I send them straight to the emergency department. I don't play around. If they have an established PCP or GP, and I'm like, this isn't really something I can handle, you should go get that taken care of. Sometimes it's a local contraindication. Sometimes it's an absolute contraindication. And the fact that I am like an entry level provider and I can see anything can walk in the door, I have to know, is that what I treat? Is that not what I treat? And I don't need to be like, I don't treat that, but no, there's no but.
Remember that patient I was telling you about? I had someone come in just with classic, unintentional weight loss, night sweats, all that stuff, and the mentor's like, "Oh, fill out an abdo exam." Da, 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 da. I'm like, "Bro, get out!" Like, this appointment is cut.
But you know what? It takes a lot of confidence to actually, and that, do you know what? It's funny, as a student, as a new graduate, it takes a lot of confidence to turn around and go, no, I'm not going to treat you. Because I've got to be honest, when I was a new grad, I'd have treated anyone. I needed the money. I'd have just taken it all. You've got shitloads of bills to pay. But it takes a lot of confidence to not only turn around to a lecturer and say, no, you need to leave, but to say to a patient, no, I can't treat you. Because some people feel like they're admitting defeat. And I don't see it as that. I actually see it as a positive. If I went to see a therapist and they said, actually, I can't treat you because it's outside of my scope, I'd actually have more respect for them. If they half-assed it and tried to do something that they're not trained to do, they get exposed very quickly, and you end up having some significant sort of lack of respect for them. So from my perspective, I'm a big fan of looking at the patient and saying, look, this is part of my skill set, I'm pretty good at it, or no, you need to go somewhere else. And not being afraid to refer, that is key. You'll refer less as you get more experienced, but also the caveat is you'll probably might miss more stuff when you get more experience as well, because you get a bit lazy. That is a bit of a problem. But yeah, have the confidence to say no, and I'm not going to treat you.
Yeah, because I've heard people say before, you should pick up one stroke a year or one stroke every 2 years. If you haven't, you've missed him. I've heard people say that before.
Same with
what's a load of nonsense, man.
Yeah.
Christ, that's like saying, what's the cancer rate? 1 in 2 now, 1 in 3. So what you should be picking up cancer every 5 minutes. Most times, 90% of the time, when you have a patient walking into your treatment room, it's going to be common things happen commonly. It's a common presentation. But when something comes in and you get that feeling on the back of your neck, that the symptoms don't add up, the case history doesn't add up, don't mess around. Just get them out. It's not worth the $100, the £100. It's not worth the money. Just get them out, get them referred. Because if something is sinister, you don't want to have missed it. You don't want to have spent time treating someone and then have to justify that treatment.
I just see so many practitioners, therapists, and doctors make mistakes because of their ego.
It's difficult because ego is the enemy. We talk about this all the time. Problem I see in osteopathy is there's a lot of very big egos in osteopathy because you spend 5 years being taught that you've almost got like magic Harry Potter hands. And you get trained that you're like the best of the best. You're like Top Gun. You're like Maverick. You're the Maverick of manual therapists. I'm an osteopath. And you get taught that you are this big swinging dick. And unfortunately, ego is the enemy. If you go into clinical practice and that's why I've got a big hatred about seeing videos of patients on tables. I don't like seeing microphones clipped to patients. I don't like seeing that because that's a self-centered treatment. That's not patient-centered. That's self-centered. That's about the therapist, not about the patient. For me, therapy is a bit like exercise. You need to leave the ego at the door. Yeah. So when you walk into the gym, you leave the ego at the door and you pick up the weight that's appropriate. If you don't leave the ego at the door and you walk in and you pick up a 300 kg, freaking barbell, you're going to hurt yourself. Ego makes you miss stuff. Ego makes you slip. Ego makes you vulnerable. Ego ultimately is going to fuck you up. So remember, like it's basic stoicism, man. It's been around for 2,000 years. Marcus Aurelius, Epictetus, all the Aristotle, all the ancient Greek Stoics. It was all about being humble, not having a big ego. Because unfortunately, there's always someone bigger, badder, stronger, and better than you. So I'm a big fan of keeping that down. As best as you can. That's my view on ego anyway. Okay. Unfortunately, osteopathy is a big one. I think maybe because we get left alone, we graduate, we stay in our own little rooms for 20 years, and our patients tell us how brilliant we are, and we get this big sort of head. I think it's a bit of a problem.
Stories
the miracle stories.
Yeah, I was talking to Luke.
Yeah,
the miracle stories. I was talking to him about the probability of treatment working, and even if you're going by a scientific method, like a p-value, if you have 100 people 5, even if the treatment's not going to work, 5 may have incidental findings based on the probability, right? So if you got 5 people out of our year group, say there's 80, close enough, say 5 of those, they got 5 people well at any given time. You're going to hear about that all through the college, and that's where you get these miracle stories. You know, you get these miracle stories sprinkled through college, and you think, because I remember you, not that you believe, not that you were endorsing it, but I remember you saying to me, like, oh, people get good changes on upper cervical, and it's like I'm sure they'll get good changes if you knock them over the head with a spade 100 times. I'm sure 5 people would get good treatment. You see what I'm saying? It's the probability thing.
It's funny that they get shared with such pride. People are unintentionally admitting that they're surprised that their treatment worked, and I find that really, really funny and also extremely concerning. It's just testimonials, and when that's quite literally all you hear during your educational experience at the college, it's really,
you're kind of in a bubble, eh?
It's really concerning. It's just a bunch of people patting each other on the back, being like, "Oh."
But isn't that the same as social media? Because let's be honest, you can bubble yourself into social media, and if you look at, for example, if you look at your university experience with these anecdotal miracles, and then you go onto Instagram, every single therapist using manipulation is putting 20, 30-second miracle clips up where the patient has all of a sudden regained their vision or regained the ability to walk, or, you know, you never see the negativity of the treatment, or you never see a treatment not work. I mean, there's an American chiropractor who was cracking the upper cervical spine of a guy who's got ankylosing spondylitis.
Yes, I saw.
And he was, and I was like, hold on a minute. Yeah. That is like, you're talking about one of the most, risky. I mean, neck manipulation for someone with AS is like completely contraindicated. I've got colleagues that have AS, and they're like, don't crack the freaking neck. And this geezer's ratcheting it because that's his new trademark technique. And I'm like, wow. And he's purporting these miracle cures. So I feel sorry for students. Thank God I didn't have social media when I went through university, because I left university thinking I was a really shit therapist, because everyone else was seeming to have these amazing results. And I was, I wasn't getting this immediate quick fix, chuck the walking sticks away. Oh my God, how did you do that? My treatments, it was a slow progression where they got steadily better. And, but you see all this stuff on social media, and it makes you sort of think, well, crikey, why am I not getting these amazing results when everyone else seems to be getting it? And you question yourself as a therapist, especially as a new graduate therapist. It can put you in a really difficult position, questioning your skill, when in reality, it's all bollocks. Like these anecdotal miracle fucking treatments, it's all bollocks. I've been doing this 15, 20 years. I can count on my hands how many times I've done a treatment and the person's gone, oh, that's 20 years of pain gone. And when they turn around and they say that to me and they say, how did you do it? My answer is, I don't fucking know. I don't know. I just got lucky. I got lucky. Because treatment is not a quick fix. It's a gradual process. And it can be very disheartening. I do feel sorry for graduates because, like I said, it's a 5-year degree. It's a lot of hard work. And if you don't have the right support network of friends and colleagues and people to keep you grounded, it can be very challenging, very challenging.
I was just going to say, like, it's finally refreshing to hear this sort of input. I guess at the end of the day, like, it's just, who you surround yourself with in college and outside. Everyone here is lateral thinkers. And when you have that around you, you're constantly questioning and challenging each other versus just getting a hard on regurgitating the same stuff. You know what I mean? Like, yeah, it's fine. It's refreshing to hear it.
You're absolutely right, because what I find is that from when I studied osteopathy, it tends to be for more sort of like older students. So when I was in my sort of mid-20s when I started my degree, and I think a lot of the time people go into these professions looking for an identity. Yeah. Looking for a group, looking for connection, looking for a network, looking for a tribe. And once you get sucked into that, you end up finding that, if you don't question it, your whole identity becomes that profession. And especially when you look at some of the tutors that are teaching you, some of the people at the university, if you were to challenge their thought process, challenge their paradigms on underlying neurophysiological mechanisms, you're almost challenging them in on a personal level. You're also almost insulting them as a person. And that's the problem with things like osteopathy and chiropractic, is that you end up getting these very, very insular little bubbles of echo chambers. These people that their whole identity is based on the philosophy and is based on the profession. And when you challenge the profession, you challenge their integrity, you challenge their value, you challenge their worth. And that's why they don't like it. That's why people in our professions tend not to want to discuss this stuff. Like I sent you that link or the research that was published by Dr. Oliver Thompson on what's wrong with osteopathy. That was a great critique research paper done this year. And Andrew McMillan was his co-author, who also has ankylosing spondylitis and is part of the AS group in the UK. And it set the whole profession up on fire, because these forward thinkers were going, well, actually, the philosophy is fundamentally wrong. And these old school osteopaths were going, no, that's outrageous. It's terrible. You're slamming the profession. I'm like, well, if we don't challenge the professions will die out. They will get lost. And unfortunately, if we want to fit in with 2023, we have to challenge. And we have to be big enough and ugly enough to admit when we're wrong. That can be really, really difficult, really difficult. I don't know about what your experience was like when you were at university, Luke, or you Brogan, but it can be very difficult if you are an outsider or you do think outside the box. You end up being ostracized. So my colleague that I write with, I was always very good at playing the game. He was a little bit more outspoken, and when he stood up and went, "Excuse me, you can't fast away cancer," he ended up getting ostracized by the tutors, and actually found that it affected his grades and marks. So you end up in a situation where you have to keep your mouth shut purely just to pass the exams. It's a really difficult position to be in.
We learned very, very quickly in college to quit stepping on eggshells, keep your mouth shut, stay in your lane. Your time in the college, you have what you call conduct reports, and you can get a max of, well, they say you can get a max of 5 before you're academically dismissed from the college. I got to about 2 or 3. That wasn't because I wasn't doing anything wrong, unethically or anything. It was just when you unintentionally challenge certain concepts and mentors, they log into your system and go, boop, conduct, and you learn very fast just to keep your head in the lane.
Yeah, trigger happy with them. I got told, because 5 conduct reports, you're kicked out of the college. Essentially, I was told I'm 20% closer to being kicked out of this, 4 or 5 year degree that I'm in for forgetting to put away an activate.
But that's like a housekeeping thing. Like Luke, I don't know how much you want to talk about it, but Luke was like, one of yours was given to you completely unethically.
Yeah, I was.
Oh, totally.
I was messaging you daily, for moral support, really. Yeah, but it was bad.
What I find really difficult about universities, and this is across the world, is that I don't know how much you guys were paying, but you're paying a huge amount of money to be there. Yeah. And you have a faculty of educators who are there to train you to be the next generation of osteo, physio, chiro, whatever it is. And the majority of them, and I'm going to be very open here, the majority of them are there because they can't make it in the real world.
Yeah.
So if you look at, for example, pay grades, right? Pay scales. So I could not afford to work at a university. I couldn't do it because I earn more. I would earn more in one treatment in clinic than I would get paid for the whole day at university. So for 30 minutes of my time in my own private practice would be literally the same pay after tax as a whole day at uni. Now, the only people that are prepared to take that type of income, they're either there for the love of it, and they're very rare. You get these older therapists who are almost like retiring type, and they're like, I want to give back. You find them, you grab them, and you learn. But the bulk of them tend to be because they're not making any money in clinical practice, and they're using university to fund their life. And they're there for the ego, they're there for the paycheck. And I've got to be honest, the majority of them are pretty shit. And so it's very difficult. You get that level of therapist who, how good can they be educating the students? I don't want to learn off some guy who's happy to earn 30 grand a year. I want to learn off the physio chiro who's making $1 million a year. I want to see what his business practice is like. I want to learn off the guy who's written the book on manipulation. I want to learn off the guy who's, teaching this stuff. That's who I want to learn off. And so I found it very frustrating when I was a student because most of my tutors were fucking useless. There were a couple that I sort of really liked, but I felt, to be honest, I spent 5 years and I learned myself. I basically felt like I did the degree. That's why I'm quite good on online learning, because I felt like I learned myself, because I wasn't really getting the education that I thought I deserved.
They never lost their religion, eh? That's why they're back.
Right?
Yeah. That's a legit. Yeah, where I got it from.
Well, during first year philosophy lectures, it was really, really interesting to have somebody's, true perspective revealed when the lecturer at the time, he was like, would you rather make this much money or $1 million a year? And he's like, I'm seeing 4 patients across 10 minutes.
Yeah,
just conveyor belt. Boom, boom, boom.
I've told Giles all about it. In fact, I was telling Giles that the most Stephen saw when he worked at his high volume place was 70 a day. Is that right, Stephen?
Wow.
Yes, it is pretty high. It was around there.
Tracy,
In the upper 70s.
That's a lot of happy endings.
Yeah.
I was never the one leaving with a happy ending, though.
Those massage parlors, mate, that's going to ruin your wrists.
fucking nuts, man.
Like I'm a graduate, so I know I got a lot to learn, but still, you don't have to be super experienced to know that I don't care who you are as a practitioner, you cannot provide an effective assessment and treatment within 2.5 minutes. That's a crock of shit.
This specific person, he also had like a mantra or like a.
That's like a sales pitch.
Religious
essentially.
zealot.
It was almost
that's
a sales pitch or like a religious, but it was like a thing that we had to learn, and it was called the guts of it, and it explained vitalistic chiropractic.
Yeah, it was a 60-second elevator pitch if you were to meet someone, and you had a minute. Essentially,
and we had to know that, and because every start of philosophy on a Wednesday morning at 7:30 a.m., he would drag someone to the front of the room
from the roll,
randomly, 2 people actually, to recite it purely from the head. So we all learned
that's religion.
Oh, absolutely.
Yeah,
and the funny thing is, Giles, is that we have people that have graduated years ago, and we see them put on these nights, right? Because that's one of the things they teach us. They taught us you have to put on these kind of community nights where your patients come and you feed them chocolate muffins and coffee, and you upskill them, or you communicate to them on the importance of wellness through chiropractic care. And we hear that they post them on social media, and we hear them, and they are reciting the same thing,
word for word.
Wow.
We could probably cite it. We won't. We probably could.
That's how bad it was ingrained into us. Yeah.
Let's hear it.
I'm not.
Okay.
Not on a public level. I have morals.
Oh, yes,
There's
brain is protected by the skull.
Yeah.
Everyone's protected by the skull.
There's
Chiropractors are the only uniquely trained profession to locate, analyze, and facilitate.
It's just
treatment of subluxation.
back rubbing.
Wow, it's just a different form of religion, I guess. It's and like I said, that's some people buy into that so strongly because it becomes who they are as an identity, and that can be quite challenging, especially when you see stuff online and when people are saying stuff online about things that just clearly are unethical. I mean, I think treating a patient in 2.5 minutes you've got to be Superman to be able to do that. Just to take, I mean, look, ultimately one of the most important parts of the treatment process is the case history. Yeah. That to me is I don't care how good you are with your hands. A good case history is what's going to keep you safe. Case history for me is so important. And if you're treating patients in 2.5 minutes, even 10 minutes, 15 minutes, you can't really get a good sense of someone's case history. Something slightly awkward, if you get someone coming in and there's something about their condition you're not sure about, you've got to question it. Open questions. You've got to try to get as much information out as you can, and it can be very difficult to do that in a very short space of time and be safe.
The case history almost doesn't get done because it's that model where he's got people, he would do a subscription model where you'd pay a weekly fee of $20 or whatever, and you can come as many times as you want. And so his whole thing was based on wellness. So he would adjust people and they'd be on this wellness plan. So there wasn't much assessment happening. And that is similar to the story I told you about the New Zealand chiropractor that got malpractice and lost in the UK. doing the same thing that we were taught at NZCC, which is under this ideology of subluxation model, and it does not stand up in the real world, does not stand up in the real medical world, does not stand up in front of proper boards to understand.
You gotta hand it to this guy though, man. If anybody actually believed the stuff he was spouting, because I reckon a lot of them don't, he was completely convinced.
Yeah, he said if you adjust anything but the spine, you're not a chiropractor.
You get this in all professions, though. You get these types of people in all professions. You'll always get the odd bad apple, as it were. It does make you question. It makes you sit there and question your whole life choice as to what you're doing.
I spent the first year being like, oh, I made a mistake. I made a big mistake. Yeah. One that is going to have very serious financial and educational ramifications. So.
Yeah, I mean, I remember Cole was circling the drain. No, you're right. I remember Cole was circling the drain and was like, I've made a mistake. And I remember me and Luke were like, we were trying to we were just looking for the best. We were just trying to find anything to hold on to. I started studying Gonstead. I downloaded everything. I bought every online book. I got sent the Australian book. I made us both copies of chapters. I read everything so that on that first day we started Gonstead, I knew it very well. And by the third week, I went to the mentor. I think it was us three. You guys were behind me, on my wings. I had my wingman here. I remember that night. And we plopped out, how many books did I have? I had my iPad, maybe 3 books. Yep. I went boom, 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 and it was hard. I had drawn things myself, and I had highlighted. It was a bit of a presentation, and he was like, oh, I'll get back to you. He never did. And that fundamental problem I found in Gonstead was proven to be true and accurate, and I talk about that in the chapter. But so it's one of those things where we gave
it a shot.
We really gave it a shot, man. Like hand on heart, we really did try. And we tried. And then when that wasn't there, I connected with Stephen and Dr. Mike and MPI, and we tried to do an MPI club. We got shut down. Like at every avenue, we were trying to create something positive out of something just not, and it was just not possible, So
tell me, how do you feel about the profession now you've graduated? So you've gone through that 5-year process, you've gone through the dogma, you've gone through the ideology, you've come out the other side. Where do you feel the chiropractic profession is? Where is it moving to? And how do you feel as graduates? Do you feel prepared? Do you feel,
Pretty much how you touched on earlier, like you're graduating now with more questions than you came in. Like Brogan touched on, first and second year, we gave everything a shot, and that gives us the right to move off in different tangents now, because we know what's wrong and we know what's right. We're not taking things for gospel, as it's said. In New Zealand, it's in a pretty steady state with how it is, which is why I'm actually heading out of the country next year, but that's at a later date. Yeah. Hopefully to come back and reunite the hub. But essentially, man, you can't find your chiros like Stephen, the way that he's practicing, he's integrating adjustments, soft tissue, all types of manual therapy, exercise. You just don't see it here. It's a complete business model that you subscribe to, and it's an easy model to subscribe to, because like we said, you can regurgitate a 60-second elevator pitch and make a lot of money, and you can make additional money when you get an X-rays in your practice, essentially. So, I hope that things in New Zealand especially do change in the future. And like you said, having different professions come together and amalgamate, essentially, because the title's all ego at the end of the day. Like, we all pretty much do the same thing.
We do, yeah. We may have different philosophies, but we do all the same thing. Yeah, you're right.
I gotta say, after this 5 years, I feel like I've just kind of reached the starting line. So obviously, there's so much that I need to learn as a practitioner, and so much experience I need to gain. But at the very least, what the college has taught me is exactly how I don't want to practice, and because of that, it's pushed me towards the right direction of, okay, this is the direction I want to upskill in. These are the type of people that I need to be around to do it. And like Luke said, this country just doesn't really support that, which is another reason that I as well am moving overseas, because a multidisciplinary approach, chiropractic, it's just physical rehabilitation. No matter, it's just a name. They take more of a practical integrative approach, which is what I'm looking for, and that's the kind of direction I want to learn in. So am I ready as a practitioner? No, of course not. Like, of course I'm not perfectly ready to go out in the world, but who is? Am I ready to start, using the skills I currently have? And like you said, when you don't know what's going on, get them out of there, refer. Yeah, of course. I've already been doing that. I've had to do it quite a few times in the center already because, if somebody comes to a clinic where it's super vitalistic and I'm concerned, but I run into the same situation as Luke, where somebody's willing to put their license on the line, that you're putting that person's life on the line or their health on the line. The license has nothing to do with it. So get them out of there. And an approach where that's normal, that's the normal, is something that I'm really looking for. Like going back to x-rays, I constantly, it's really backwards. You'll have to justify why you don't want to take x-rays rather than why you do.
Wow.
It's a very, very concerning environment to be in. We have a structure. So you have a new patient appointment, a report of findings, regular appointments, and then a progress visit where you do a basic reevaluation. After I tried to implement corrective exercises into my therapy as an intern, even after getting everything signed, even after getting everything approved, the shitstorm that it ended up creating caused the college to react by saying, okay, now you can't implement any corrective exercises, any lifestyle advice until the progress visit. So until this person has come in for 8 to 12 visits.
Wow, 8 to 12 visits. Wow. Oh, wow. Because ultimately, am I outdated here when all of the research says that manual therapy, when combined with exercise rehab, has a better therapeutic outcome for the patient on pain levels and disability scores? That exercise rehab, or, manual therapy on its own is limited. That the combination of the two is where we need to be as practitioners.
Well,
wow.
Passive treatment by itself is not going to be enough, especially not long term. But it's funny you say that, because the justification was, well, see just how far they can come with chiropractic alone. Why? I don't care. And neither does this person. They're in pain. They want to get out of pain. So it's my goal to help them become functional again and reduce their pain levels.
You have to wait weeks. So if they're coming in once a week, that's 8 to 10 weeks.
I've referred people out on that basis of, I know that the college is going to hamstring me so much with this case that I cannot be a good practitioner in this case. And it's so
shocking. Yeah.
It's shocking.
I've got to be honest, I teach a lot of practitioners. I teach lots of practitioners all over the world, and it never surprises me how many practitioners don't exercise themselves, that don't actually engage in any form of exercise rehab, any form of physical activity. They don't know how to prescribe exercise. They don't know what they're doing when they're prescribing exercise. And it's really disheartening. I mean, crikey, as a healthcare provider, you at least have a basic understanding of how to program a movement, how to introduce some. I mean, Christ, it's not difficult to give someone a walk, for 20 minutes every day. Walking is incredibly beneficial for the patient. Just do that if you don't know what you're doing. But the amount of times I see therapists who purely rely on passive intervention, hoping that is going to cure their patient's pain. And the reality is, they may get lucky, but most of the time you need to have some form of exercise rehab. Otherwise, you're just going to go round in a circle.
But going back to just briefly what you were talking about, you get to the point where you've been through school, you've been taught all that stuff. Think about what's being left on the shelf that hasn't been taught that should be taught. And we can talk about corrective exercise. We can talk about active interventions. We can talk about all that stuff, and that's important and whatnot. But let's just take a step back and talk about the power a therapist, a clinician, or a practitioner has just with communicating the importance of exercise, communicating the importance of lifestyle change. When we've got all of this epidemiological or population data clearly showing us just how important exercise is. Like if you take someone from below average to above average fitness based on VO2 or MET, we're going to see a reduction in all-cause mortality from 60 to 70%, right? If you've got someone that is directly linear between grip strength and all-cause mortality going down, all of these things. We've been talking about this research recently. I've been sending research to Giles. I did something on social media. This is not oh, we're going to do bird dogs, or we're going to do like interventions to help with the back pain. This is like take one step back. Let's just think about just general across the population. We need to move more. We need to eat less refined foods. We need to drop sugar.
Well,
we need to drop all I'm not here to talk about nutrition. That's not my scope, so I'm not going to do that. But what I do understand is exercise, and especially strength training, improving your VO2, improving your fitness, improving your strength is going to allow you to move and be happy when you're 80. And that should be a lot of people. That should be people's goals, I think, ultimately. It's not, but it should be.
There was this I think it was an MRI of it was two 74-year-olds, one of them sedentary, the other one like an active marathon runner. And sometimes
they looked at the quad, wasn't it? And the quad was massive. Yeah.
Muscle density, and I would show that to some of my patients.
The other one had fatty infiltrate.
Yeah. It was like, it was strings and fat.
I've seen many of those on the multifidine. Yeah.
But I think things like that is a great educational tool. Instead of taking X-rays, just show a demonstration of like, obviously this doesn't necessarily apply to you, but if you stay active and you take the necessary precautions now while you're young, you can maintain that for longer and you will be healthier and more functional.
But talking about osteoporosis, like there's research that is very contradicting with, because I know a lot of people say, oh, go for a walk, which is important and has many benefits. But there's research that says it's not enough. It's not enough load bearing.
You need to load. You need to load, and ultimately,
if you go walking, you're going to be loaded. It's like just not enough.
No. You need to load. I mean, I've got to be honest. If we're talking about like the educational aspect, if they got rid of half of the bullshit that we have to study for the 5 years, stuck in some really good knowledge around basic nutrition, basic exercise rehab, some understanding about communication, got rid of, like, from my degree, we didn't really do any exercise rehab, any real good nutrition advice. It was all, passive intervention for 5 years. Get rid of a load of misinformation, stick in some good physio rehab, stick in some nutrition stuff, stick in some communication stuff. And I think you've actually got a better therapist. But trying to explain to your patients the importance of exercising now so you can move well in your 70s and 80s is fundamental. So half of what we do is a psychological intervention. We discuss with our patients the benefits of doing these things, because the difference between health span and lifespan, is massive. You can have a lifespan of getting into your mid 80s, but your health span, they reckon by the time you hit 60, you're going to have some form of medication, one or two. You want to try to be as fit and active as you can for as long as possible.
We're about 10 years apart, and then we're about 10 years apart, me and you, Giles. So we're all going to have slightly different worldviews. But I know when you look at the boomers, they tend to be like the boomers and their parents, like our grandparents or my grandparents, I suppose your grandparents too. Yeah. And definitely you, Giles, your generation, your grandparents, you got used to old people being sick. It was the normal. Old people were sick. Yeah. Old people were on medication. They were in wheelchairs. They couldn't walk. They're at home. So sick. And I think we are seeing less of that, hopefully. But I think we should. There's really no reason why we shouldn't see a decrease in that as the knowledge starts to rise and understanding nutrition and exercise and having the interventions earlier.
I would like to say that I would like to hope that's the case. I would like to hope that with access to the internet and ChatGPT, obviously, people have access to knowledge that they didn't have, back in the day. But the reality is that we are seeing higher levels of obesity and metabolic disease and blood pressure and cardiovascular issues now, when medicine and society is so much more advanced. So I don't think it's a lack of education, lack of awareness. I just think it's a lack of motivation. And there's a huge amount of people that just can't be fucked to do anything. Everyone's looking for a quick fix. Click my neck, take away 10 years of back pain, give me 6-minute abs. Anything worth doing takes time. Anything worth investing in takes time. I mean, no, I was chatting to you yesterday, Saturday night, and I was reading research on on manipulation and cavitation. If you want to be ahead of the game, you got to constantly be learning. Fitness and health for me is really important. So this morning I did 5K, came back, and then I was working on the osteoporosis thing. So if you want to do it, you can find the time to do it. But trying to get the patient to understand the importance and actually do something, is very hard sometimes. 80% non-compliance you see in private practice. Half the time, my goal with my patient is to get them to do something. They don't have to do backflips and CrossFit, but just to do something and to stress the importance of that, to get them into that healthy habit is really, really important. And that's more important than clicking any joint in the body. I don't care how good you are at manipulation, how good you are at acupuncture or needling. I don't give a monkeys. Click whatever you want. I would be more impressed if you managed to get someone who's sedentary to do a 20-minute walk every day. That is more important. And in fact, do you know what? Sometimes don't go to the therapist, save the money and use it for a month's gym membership. You're going to get more out of it than having some numpty try to ring ding at you. Go to the gym for a month and do some cardio. I don't care. Roll around on a mat, do something. It's really, that's for me, that's the most important part of the treatment process, getting the person to understand that type of message.
Yeah, and helping people with the on-ramp to exercise is something I'm passionate about, because people will see a powerlifter or they'll see someone that's in good shape and they'll be like, well, it's easy for you, you love it. And it's like, well, we don't love it every day. Like, it's become just part of who we are. I know if I pick up the phone and call Luke, I'm going to have him puffing on the other end because he's at the gym at a certain time.
He's working on one of those chat lines.
Like, if you're going to call me between a certain time, you're going to get me puffing on my phone, like, while I'm working out. And even, when I message you and we're talking about stuff and you're like, oh yeah, I'm off to do this and I'm off to do that, I'm off to do a 5K or whatever. It just becomes part of who you are, man. And so it's like, how can we implement strategies to help our patients understand that and to start small and build to something better? Because once you start here and you start making progress, it does become moreish. Like, I think everybody here understands that feeling of where you get up in the morning and you've set yourself just a habit and you feel drawn to the gym and it becomes easier.
What do we call it, Brogan? Just brushing your teeth, bro. That's all it is. Just
actually
non-negotiable.
It's a non-negotiable.
Actually, yeah, Giles, how would you go about, just as a grad, how would you go about effectively communicating that, the importance of just getting into it? Because so far, like, the approach I've tried is like, getting them to take baby steps into it. But
I think that's probably the most important. I think that's probably the sensible approach. Well, I would always say to use the KISS mnemonic. Keep it simple, stupid. Keep it simple. So we used to give patients these big diatribe lists of exercises that they need to do, and they just wouldn't do any of it. So for me, when I'm working with a patient that doesn't do exercise or is might reluctant to do it, I do something as simple as I can for that one intervention. So I don't care what it is. If, for example, lower back pain, I would say, right, all I want you to do is once a day, turn your phone off and go for a 15-minute walk. I don't care what it is. If you can find 15 minutes, just do that. Don't worry about doing any exercise whatsoever. Let's just turn the phone off, go for a 15-minute walk or whatever, just chill out, and let's get you into a habit. So start off with a layered approach. So my treatment is layered. My rehab is layered. I'm doing the least I can to get the most out of it, and then I build and build and build. And for me, if it's a shoulder problem, if it's a back problem, if it's a knee problem, I would look at basically giving them one thing to do, just one. Give it as simple as you can. See how they respond to that after 1 or 2 weeks, and then you can add something else and add something else. If you chuck everything at the patient straight away, in fact, if you do that with a manual therapy intervention, if you rub it, wiggle it, click it, crack it, smash it, you're not going to know what's going to work. If you give them 100 exercises and they're not used to it, you're just not going to know what's going to be working for them. So I tend to say keep it as simple as you can.
It's knowing the most bang for your buck exercises in this situation.
Yeah.
One person to follow for that is Andrew Locke, because Andrew Locke's he brings together basic concepts and he'll put it into like a series of things you can do. I know with the Locke 5, it's for the lower back. He pretty much works his way in to hip extension. So if you got someone that's having lower back pain and you got them to sit down and start doing hip extension stuff immediately, there's a high chance they're going to recruit the erectors immediately. They're going to struggle with hip extension. Yeah. High chance, right? Not always, but a lot of the time. So what he'll do is he'll work around it, right, with reciprocal inhibition, and he'll start with the glutes, start with the med, go in, and then core stability, right, and then slowly he'll get to the point where he's got the person on the ground doing a very minor hip extension, and then he'll move into a full extension, and then he'll take them into something like McGill 3 if it's appropriate. But yeah,
but that's a layered approach, and I think that's a sensible thing. With your treatment, you layer it. Yeah, with your rehab, you layer it, and it's all about adding adding that nuance, adding that stress, adding that difficulty, adding that challenge, building, because rehab, manual therapy, exercise, bodybuilding, lifting weight, it's a long, slow process. For me, when I see my patients, especially like first patients, I turn around and go, this isn't a quick fix. If you're looking for a quick fix, go and take the drugs. Because it's not a quick fix. This is a process, and we're going to try and get through it as fast as possible. But it could be a week, it could be 2 weeks, it could be a month, it could be, it's a slow process. Getting that across can be really hard. It's a bit like frozen shoulder, for example. But they did the Frost report back a couple of years ago. They looked at all the interventions for frozen shoulders. The key thing with that whole process: lower your fucking expectations. Say to the patient, lower your expectations. That is key, because we're going to be seeing each other for years.
Do you reckon it's the environment too? When you're trying to prescribe exercise and basic therapeutic work to patients, like if you're operating out of a clinic that has freaking, spinal degeneration models hanging around and posters, and you're in a tie and a suit, versus they walk in, immediately see kettlebells, resistance bands, squat racks. Are they more compliant to adhere to that lifestyle advice, do you find?
Interesting about perception, patient perception and clinical perception, because it can have a massive impact on pain, and it can have a massive impact on how well the client responds to the treatment. I think for me, I've always worked in an environment where there's been exercise equipment around. So for me, it's a non-negotiable. Patient comes in, they're going to get some form of exercise rehab. If you work in an environment where you are suited and booted and you don't have anything like that, it can be a little bit harder as a sell, to be honest. Because I think for me, the best treatment is, maybe you're on the couch one session, the next session you're in the gym, then the third session you're back in the table.
It looks like a medical doctor's office. You walk in there, there's nothing that screams to you any type of exercise or it literally just feels sterile. It feels like a GP is about to freaking stick a needle in your ass or give you some drugs.
Well, so our clinic was operated out of one massive room with 15 treatment tables in one room. And if I was a patient walking into that, I would immediately think, like, my role is to lie on the table and for the practitioner to, rub, dub, whack, slap, you know what I mean?
It really promotes a negative image of the profession. And to have treatment in a room where there's 15 other patients as well, I mean, how can you actually do any decent discussion with that person? How can they open up to you and talk about some, their presentations or their findings, if they're feeling vulnerable in that situation?
There's 15 other people around you, right? Plus there's mentors, and it's really 30, because then you've got the Chiro students that are there as well. And there is no, I've overheard people talking about sensitive stuff. I've had to talk about sensitive stuff while people are watching. Like there really is no kind of respect, or and there's a couple of rooms that you can go in, but it's really it's a bit of an issue. Then the gowns are the worst part. Sorry, you have to put them in these gowns, and the girls can't wear their bras because you have to be able to palpate. You have to be able to palpate the multifidi, right? Because
of course you can, yeah.
Static listing, right? and tests would fail if we didn't take the bra off.
And keep in mind, in clinic, we just ignored it. I'm not gonna do that. I refuse.
But in a test, remember
in the test setting is. But
to be honest, mate, also half the time you're making it up as well. You're just trying to feel shit that you're just making it up for the instructor half the time.
I was looking at the size of the musculature that we were claiming to palpate in virtual reality, and I was getting to expand these models, and I was peeling back the layers of muscles. And
virtual reality,
I was like, "There's not a fucking chance. There's no way." The superior oblique and all the little muscles of C2. Rectus. Are you kidding me? There is no way you can palpate hypertension when there's
C2
4 layers of muscle.
It's the same. If you've ever done cadaver studies, you've cut the patient open and you've looked at the spinal segments, you've looked at the vertebra. How the fuck can you palpate that? Like motion palpation in that type of rotated, side bent, this, that, up, down, left, right. It's just mysticism. And that's why we were talking yesterday or the other day about some of these old theories about things like Frye's law and coupled motion and all this type of stuff being used to identify areas where you are trying to treat. you know, the excuse that some people have is that, well, it's a theory. It's better than having no theory. It's better to have some theory than none. My argument would be, well, you know, that's like using a divining rod to find gold. Yeah, it's a theory. It doesn't mean it's fucking true. You know, I would rather you have your hands up and go, actually, I'm just seeing if it hurts. And if it hurts, pain provocation, I'm probably on the right spot. And then we can work around it.
Stephen, you probably have a really good experience with this because you've probably seen the difference between bad motion palpation and good motion palpation. And I say that that there is a caveat in isolated communities where they do get pretty good outcomes when they are teaching strictly from really good professors or mentors or teachers down. And the MPI movement tends to do that pretty well, right, Stephen?
Yeah, they don't claim to be able to identify like those minute listings. Like that's not a thing. They just identify there's a restricted motion roughly in these joints. They're not like, oh, it's a C7 TLI. Like no, they're like in the CT junction. We've got some restricted lateral bending, some rotation deficits, stuff like that. And yeah, you can pick those things up if you practice long enough. The minute, like the axial spring and stuff, like you can't do that. There's 2 to 6 inches of tissue between your thumb and that spinous process. You just can't.
Oh, the best one is adding a rotational component to the adjustment.
Oh, Brogan and Stephen. Yeah. You mean like?
Oh yeah, the torque.
Like, Giles knows all about this because we're writing a book on this, and Giles is doing all the techniques.
Yeah,
and so it's so funny.
Oh fuck! Right, okay. So you're talking about the upper cervical toggle type thing.
That's one of them. Yeah,
knee chest is the same. You know, with the knee chest, how you can't just go. The vector's not just PA. You have to then do the rotation based on.
Yeah, but that's not how I'm going to do it, mate. Because I'm reinventing Gonstead for 2023, and all that shit's being cut out because it's all fucking nonsense. Like you're going to do the thoracics. It's going to be P to A or A to P. Don't add rotation. Don't worry about it. It's just, you know, it's going to be the drive is either downwards or upwards. Some of this toggle stuff, you know, the hammer hand, the nail hand, the Timony type, the upper OA flick, the recoil. Oh my days, they've got some fucking magic, man. They've got some proper magic. I've seen some crazy stuff. Now's the fun stuff. You can now go and learn and research what you want to, and you can go and work with other professionals and actually, work out who you want to be as practitioners. That's the good bit. You can just pick and choose what you fancy. Always critique. Yeah, don't be afraid to reach out if you want any advice or any help or anything like that. And do me a favor, literally spend 25 minutes to half an hour every day and just grab a journal, grab a book, grab something and just read just for 30 minutes a day. And you will be surprised how much knowledge you get in a couple of weeks, couple of months, couple of years. Seriously, every day I try and do something. I've got a little notebook that I carry with me. If I see something interesting, I write it in it. I've got hundreds of them and you'll be surprised. So just literally do that every day. And these little things add up. Really, really does. That 1%, man, 1% improvement every day makes massive changes. But listen, well done. Anyway, congratulations.
Cheers, mate. Appreciate it.
Thank you so much, Giles, for coming. If you want to see more about what Giles does, you can go to omttraining.com. And there's
my OnlyFans page. Osteopathy ain't cutting it, mate. I'm on OnlyFans. That's where I'm making the big bucks.
Osteo.jasonstatham.com.
Osteopathy
training. There's free courses. There's comprehensive courses. There are courses, large courses, small courses, fat courses, skinny courses. Whatever you need, whatever is your fetish. Are we talking about?
Whatever floats your boat,
man. So OnlyFans or OMT? Anyway, so go to that, check it out. 5 books you can also get. And what he said to these lads goes for everybody. Read something every day. There's 5 books you can get with Giles. On top of that, read his research and read research in general. Okay, let's not be abstract warriors. Read journals and research. If you
just get ChatGPT to do it.
Yeah, well, I told him about that, Stephen. Full circle moment there. I'll have to pull you guys in.
Yeah, please.
But anyway, I'll let you go back to your family. Thank you for your time. It's a Sunday night.
Take it easy.
Really
worries.
appreciate it, Giles.
Take it easy, guys. See you later.
Awesome.